Good evening, and tonight we're going to talk about aging. Hopefully, we'll talk about successful aging. It's very difficult for each of us to decide who is old. That depends on if we're talking about somebody we love, admire, and respect versus somebody we don't. We talk about somebody who we're related to versus somebody we're not. And we talk about what is the difference between aging, end of life, and chronic health conditions. And nobody really has that simple answer. So your goal is anytime you're involved in a conversation about what is appropriate aging versus what is disease, you have to talk to the patient and family and understand how they view it. And then hopefully that all of you can come to some consensus about what is appropriate aging, what is not appropriate aging for that person. We all talk about getting older because there are many benefits to getting older. Remember when you were a child, you thought that everything, the whole world would open up to you turning the age of 21. And then at some point, and being a young person, it was very important to tell people whether you were 6 or 6.5 or 6 or 3/4 or almost 7 and 7. And then at some point in our lives, we don't tell how old we are. And then as we get older, I'm interested in people who are over age 75, and they're always telling me when I ask them how old they are, how old they're going to be on their next birthday. So as we get older, many people are very proud of how old they are. Some people are less excited about aging and what aging means to them. For many people, it means poverty. It means being alone, and it means infirmed. It means not being able to drive. It means not having money to buy the food that you want, not having the eyesight or the hand coordination to cook the food you want, and not having people to support you when you can't do things by yourself with love and respect. So what is the definition of aging? And it's just getting older. And we talk about what are the different ages, and if definition is chronological, then we have young adult 65 to 7, middle age 75 to 80, and then the old, which is 85 and older. Now, the 85 and older is the fastest growing age group in the United States. Keep that in mind. Although in the year 2015, it's estimated that 1 in 5 people would be between the ages of 55 and 64. So those baby boomers, and I'm one of them, are getting older and better. When I was reading about what is the elderly, and there's different terms applied to the elderly population, it is assumed that anybody who's old enough to collect Social Security is considered the elderly. Also, old age, we talk about physiological age, and that's age by body function. And I'm sure when you write your general statement for a physical exam, you say 26-year-old female who looks stated age and no acute distress. And then as you get older, you say 68-year-old lady who looks younger than stated age or older as stated age. That's a very subjective statement, but sometimes people do look older for whatever reason, whether it's personal neglect or the neglect that comes with chronic disease. People do look old. Now, the elite old are those people over 100 years, and I was looking up statistics about how many people are over the age of 85 over the age of 100, and it's in the millions, but that number doesn't mean anything to me. I don't know who lives the longest. I was reading an article about what is included in healthy aging, and about 30% of your aging is related to genetics, and 30% is chance, and 30% is lifestyle. But remember that 30% is what we consistently quote in healthcare. So, which states are the grayer? And this is just a pictorial representation of who has what states have people who are older, what that matters to a state if they have a Medicare budget or a Medicaid budget, how much of their healthcare expenditure is based on people's last few years of life. And this is aging in U.S. population total numbers by age group. And as you can see, those people over the age of 75 are growing. Why this is important to us is our goal is to, we believe as nurse practitioners, we can interact with people at a younger age and promote healthy living, cancer screenings, and use of a healthy diet, no smoking, and exercising. Maybe people can live longer with decreased morbidity, if not decreased mortality. Once again, young old, middle old, and old, and then the elite old over 100. We talk about physiological age, functional age, and chronological age. When we talk about aging, at some point you have to decide, is someone getting older and aging, or are they at the end of their life? And when they do studies on determining for any of the chronic diseases, end-stage COPD, end-stage CHF, end-stage cancer, if physicians or providers can determine how long a person has to live, and they compare the provider's expectation with the patient and the families, there is no consensus between all those three groups of people or how much time is left. And it's important for us to know that. I'm pretty sure that 6 months for living came about when the AIDS epidemic was at its height. And why this kind of came about is if a person with HIV could be put on hospice with 6 months of life left, they could sell their insurance policy to somebody, and that person may take care of them for that amount of money if they had 6 months or more to live. So there's a reason. That's usually, I've said before, that in healthcare, the reason there are guidelines or statements about certain things we do or don't do in healthcare, it depends on money. So there is some money to be gained, and mainly it's by the hospice organizations if somebody has 6 months or less to live of life. Once again, we don't know that. And then now we talk about hospice and then palliative care, and I'm not quite sure of the difference. Hopefully palliative care just means that you focus on quality of life versus quantitative of life, and then hospice is for the person who's actively dying. And you have to decide with the patient and the family where that person fits, whether it's healthy aging, where it's the goal should be from preventative health care to quality of life versus quantity of life. And then when the patient and the family should determine that the end of life should be spent in hospice and the goal of care should be comfort only with no further blood draws, IV antibiotics, those kinds of treatments that don't change the quality or the quantity of the patient's life. And if you go on Google and you put quotes for healthy aging, there's lots of them from a lot of celebrities. So you might have a specific quote that you have for what is healthy aging and how we admire healthy aging, how we want to be part of it. I can look at, I was at the movies Friday night, and there's yet another movie by Clint Eastwood, and I'm sure he's in his mid-80s, and he still produces excellent films in my estimation, but he's actively working. And you can quote all those people that are above 80 who are actively employed, gainfully employed, continue to use those brains, but I don't know that those are the majority of people over age 85. So what are the theories of aging? Is it a program theory, meaning that when we're born, each of our cells are programmed to replicate so many times or last so many times and then they die? Is it an error theory where the cells interact with other parts of the body, and after so many interactions, the DNA and the RNA change, and then the cell doesn't function in the same manner, and so that organ as a whole doesn't function? Is it a cellular theory? Is it a free radical theory? We talk about that all the time. What produces free radicals, how we can decrease those. I always think of free radicals as teenagers gone amok in my body, and the goal is to calm them down. sometimes free radicals can change so many of the cellular functions, and they act like a virus. They get in the cell and change the DNA and the RNA. And so that changes the cell level function as well as the organ level function. The collagen theory of aging, as we get older, collagen is less produced, and does this have a total effect on the body? Now, I live in Alabama, and nurse practitioners cannot take advantage of the collagen theory of aging because we're not allowed to do fillers in this state. Only PAs are allowed to do that. I don't know how it is in your state, but dermatology seems to be an area where many PAs and NPs go to, depending on their state, because it's a money business, meaning people come in with cash and they give lots of money to maintain whatever that youthful appearance is. I know that I've said before, I think the Derm DNP program, I think it's either in Gainesville or Tallahassee, is a very popular program. And then neuroaging, as the cell ages, does it at some point just start to die? And we talk about what is the main function of the body, and that are what controls the functions of the body, and that's the neuroendocrine system. And that really means that there's our messengers in our body that tell all of our cells how to act, and this is really the nerve transmission. As we get older, those transmissions become faulty and sporadic, and so different parts of our body don't work as well. So we're going to talk about what are the different parts of the body. We're talking about aging, skin, hair, and nails. Your skin changes, and the collagen under it changes, and the musculature changes. The percentage of water in the body changes. So we have a wrinkling and skin flapping, and you might notice this on your face, on your chin, on the back of your hands, on your arms, on your legs. Many people look in the mirror and they don't like the way they are, so they get things filled and they get tightened. I know I was talking to one person that works in dermatology, and she was talking about how people are changing the back of their hands because they say when they shake hands, that's how people tell how old they are, what the skin on the back of their hands look like. Therapies as female. What was it? Nora Ephron wrote the book about the aging neck. And many of your older stars, you'll notice females wear collars and scarves on their necks because it's very hard to get the neck tight so it looks real. The nails change as well, as does the amount of hair and the distribution of the hair. Once again, the skin aging. It's a vicious circle of skin aging. And now we talk about exposure to ultraviolet, UA, and UVB, or whatever they are, and the importance of wearing sunblock. You have to put it on. You have to put it on frequently. And the real goal is to avoid exposure to the sun, not to put sunblock on. I've lived in the sun most of my life, and I really like it. And I can also tell you that I've had several cancers and surgeries on my face that has cost thousands and thousands of dollars, and will continue to cost that much money. So the vicious circle of skin aging is upon me. Hopefully it's not upon you. Aging changes with vision. We talk about the three most common eye changes, and that would be cataracts. Just a moment, it's not changing for me. Bear with me. I can see clearly, but I can't get this to go over. Well, I'll just talk about the age changes vision, macular degeneration, and glaucoma and cataracts. It has to do with the elasticity of the lens. Now we know that cataract surgery, bilateral cataract surgery, is what we do so often when people have the clouding of the vision. And you can have different kinds of lenses placed in depending on how much money you have. The goal is any type of decreased vision preventable? And you want to be clear on that, especially with your diabetics, is to have them go to an ophthalmologist on a yearly basis so they can have some laser treatments or medication treatments to maintain their vision. The hearing changes at age 50. We actually have hearing changes. Men have different types of hearing changes than do the women. If you are exposed to even a single high frequency level of noise, i.e. a gunshot close to your head in a canyon, you can have changes in your ear damage, in your ear function. We don't know if wearing earphones over an extended period of time at certain ages will cause hearing damage. Aging respiratory, the lung function changes as we get older, and then you have a cumulative effect of the situations that you've been involved with in your respiratory, whether it's interacting with environmental chemicals or personal chemicals, i.e. smoking. And so all of that changes. You're more apt to have shortness of breath, dyspnea on exertion because of decreased lung volume. And for those people who are baby boomers, they grew up with smoking, and so many have 40, 50, 100 pack years behind them, even though they've quit, and they end up with COPD of a specific age, as well as emphysema and bronchitis, which make up COPD. And then some theorists actually talk about asthma as the triad, in the triad of being COPD. So you have your pink puffers and your blue bloaters. I'd like to say that we won't have as much COPD-related illnesses in the future. I don't know much about smoking. What do they call that? Electronic cigarettes, and somebody said it the other day, the hookah pipes and different ways of inhaling a smoke. I don't know if those will have an effect on our pulmonary function, i.e., as well as marijuana. The aging cardiovascular system, the heart, when it's born, is only going to beat so many times. As it gets older, the three responses that the heart has to stress, and stress is anytime the heart is asked to pump more blood to the body, is that the stress response is it increase the heart rate. So your normal heart rate is 60, so anytime your heart rate has to beat faster, it may beat less length of time, or it can get sicker, and that's called hypertrophy, and you see that on chest x-rays with uncontrolled hypertension. And then the other one is cardiomyopathy, where the heart balloons out and it becomes thinner. So these are the changes in the cardiovascular system, and it also has to do with calcium. If you do x-rays of patients, CT of their chest as they get older, it will tell you what their calcium is and if they have atherosclerotic disease. So we have, and as we get older, we're more apt to get atrial fibrillation, which is changes in the electrical system of the heart, especially if it's non-valvular, so that pauses or rhythm eccentricities. You can have AV blocks. And why that's so important to us as females is heart disease is the leading killer of us females, whereas lung cancer is the leading killer of the men. So anytime that we as nurse practitioners can impart with our patients to lead a healthier lifestyle, to maintain their heart as long as they can in the best condition they can with appropriate exercise, diet, that's the best for them. Now, I'm sorry these slides are not going over. I'm not quite sure why that's happening. We do have a thunderstorm going on here in Alabama. So you have the slides that I've sent to you. So your goal is to interact with patients before they get cardiovascular disease, whether you used the Framingham risk score to determine what the risk of cardiovascular disease is in the next 5 to 10 years, whether it's moderate or major, and to change their healthy lifestyle behaviors so that they have less cardiac events. The aging GI system, anywhere from the tongue is drier. We have less saliva in the mouth, which means that we have changes in our teeth function. It's more difficult for us to swallow as we get older. We can have erosions in the esophagus. We had a person one time that actually came in, and they were trying to swallow a potassium chloride pill, and they couldn't get it down, and it caused a stoppage and gastritis at one area. And why I say this to you is people get older and some people take their pills without water. Your goal is to make sure that they do drink water so it slides down, especially those terrible potassium chloride pills. The liver changes. The liver doesn't respond to stress with healthiness. We have the fatty liver, cirrhosis of the liver. We have less hepatitis B and A going around, but now we have hepatitis C. And I think aren't the guidelines I don't know what the guidelines are for we screen once in your life for hepatitis C. The stomach, which is behind the heart, it changes. There's less acids released when you eat something, that you have a slowing of the contents from the stomach to the bowel. So that's in essence a gastroparesis. The gallbladder, you tend to have sludge or gallstones. The pancreas, if you've engaged with any alcohol, anybody who drinks 2 or more drinks of alcohol a night is much more prone to get acute pancreatitis, and acute pancreatitis turns into chronic pancreatitis, although pancreatitis can also be a side effect of gallbladder sludge. We have problems with the large intestines, the small intestines. We can do colon cancer screening, and that's nice to see a polyp and take that out, but you still end up with colon cancer or diverticulosis, which is a common problem in any of the person over the age of 50, and that's the pouching of the colon, and then diverticulitis. And then we have problems with the rectum and the anus. Some people hold their stool. Some people can't get their stool out. The definition of constipation is less than 1 bowel movement every 3 days. Yeah, but it really doesn't matter what the book says is the definition of constipation. It matters if that person feels that they have had emptying of their bowels on the routine basis. I can remember in the 80s when they said not to use Senokot or laxatives on a routine basis, that the gut would become dependent on it. Now they don't say that. Everybody's on Pepcid and Miralax and Senokot and Ducalax, and you increase the fiber, you increase the water. Sometimes I know people take Metamucil without taking water and they don't move, so then they just have a constipation with Metamucil. So you have to be aware of all the changes in the GI system and recognize when it's something that can be fixed, something that can be looked at, whether it's a CT scan. Remember that you can't use contrast if they have an elevated creatinine. And you have to always talk about the GI with the GI doctors is what is to the patient, and also with the elderly, do I really want to look for something? If you have a 85-year-old who is frail and lying in the bed and they have bleeding of the rectum, how much do I want to look to see what the cause of that is? If it's only a melon in a stool versus a bright red blood, do I really want to put them under a colonoscopy and go in there and fix anything? So once again, you have to look at what are the normal functions of aging and what is a disease entity and where those two might meet, and talk to your patient and family about when to screen and when to work up problems. And these are some of the problems that we have with the aging, the hemorrhoids, the polyps, the carcer, the colitis, ischemic colitis. And keep in mind that if you have cardiovascular disease, which is obstructive coronary disease, that then you have atherosclerosis disease all over the body. And so you can end up with mesenteric ischemic colitis, and you can have blockage of any of the arteries throughout your body, whether it's peripheral vascular disease, which includes the arteries to your kidneys, the arteries to your stomach, the arteries to your legs. So you always have to, the carotids to your brain. So you always have to be aware of anyone who has obstructive coronary disease to be sensitive and to look at other areas of the body. Are they getting the appropriate blood flow? In terms of the reproductive functions of the elderly, I know we talk about the men and testosterone and erectile dysfunction. Still unsure the definition of both of those, although if you watch the Golf Channel on Sunday, you will be led to believe that every man has erectile dysfunction and needs Viagra or Cialis, and every man has BPH and needs to be on drugs or have some type of therapy so that he doesn't get up 5 times during the night. And that's important. Women, we don't have as much on the aging of the woman, although there is a new commercial for women, and I can't tell you the name of it. It's not a lubricant. It's for sexual satisfaction. They're working on finding is there testosterone levels in the female that can be changed, and hormonal pellets that can be used for the male or the female for estrogen and progesterone to delay the effects of local aging, i.e. vaginal dryness for the female, or actually aging throughout the body. We all know that all of us live on hormones. Hormones are the chemical messengers between the body parts. So whether they're sexual hormones or any kind of hormones, it's what we live by. And women in death, women, disease of the heart. So we look at those and we say, can we screen for those? Can we prevent those? How do we get the person to engage in healthy lifestyle? I know when you were doing the health assessment, I would ask you, in your SOAP note to identify how much they drank. The risk for breast cancer goes up if you have more than 1 alcoholic drink a day as a female. The risk for so many diseases for the men go up if you have more than 2 alcoholic drinks per day, whether it's cancer or mouth cancer or hepatitis or cirrhosis of the liver or cancer of the stomach. So we have to be aware of what is the lifestyle behaviors that change from normal aging to disease, and how to discuss that with patients and ask them what they're willing to change and if they know the effects of what the lifestyle behaviors they're engaged in. And I thought this was interesting that even though the cardiovascular disease mortality trends are going down for men, they're going up for women. We're having some help by actually identifying with women when they have changes in their sleep habits, become nervous and anxious, and shortness of breath. That actually may be a myocardial infarction. We're doing the Framingham Risk Score on women. We're actually screening for women. You know, the stress test, the Bruce Protocol stress test is not as good on women for identifying single vessel disease as it is for the man. Now they have the Lexogram, isn't it the Lexa scan stress test, or the Echo stress test, and we even have calcium scoring for women. We want to find out do they have calcium enough or obstructive disease enough that and it depends on what article you read, when you can actually do single vessel stenting or double vessel stenting. So you want to challenge the patient before they end up with an MI, and because MI is muscle, and you end up with many more problems after an MI if you can prevent an MI. Once again, women present differently, and so sometimes we as providers may miss the subtle clue that a woman has when she's in your office for changes in her sleeping and her anxiety level as a sign of changes in myocardial perfusion. And as we get older, obviously cancer, remember, cancer is a behavior of cell. It invades other cell and it transfers itself to other parts of the body. It metastasizes. and that's part of those cells replicating. And so the goal is, what can we do to decrease the chances of cancer, or to find cancer at an earlier stage where it's curable, recognizing that the word curable means that in 5 years after initial diagnosis, there's no disease. And it's important for each of you to know, at what age do we quit screening. And sometimes people put an age plus health status to determine that there no longer needs to be screening. For the musco and neuro, there's a change in adipose tissue and nerve transmission. Musculoskeletal, the most common disease entity in people over 50 is arthritis and then diverticulosis. These are the common skeletal conditions: rheumatoid arthritis, osteoarthritis, back pain, gout, polymyalgia rheumatica, osteoporosis. Now we say we screen people over age 65 for osteoporosis. And there are some benefits and risks of the biophosphonates, so please know those in treating. And now the new thing is vitamin D deficiency. Can that make people stronger? So when we talk about musculoskeletal and neuro, we talk about falls, because falls in the elderly, what is the statistic? If you fall, it increases your chance of dying in the next year by 50%. Recognizing that falls and balance go closely together, whether it's a change in your vision, change in the strength of your muscle of your legs so that you can't pick up your feet, and that causes falling, changes in the shoes that you wear, whether they're too small or too big. If you're wearing pantyhose, I guess we don't even use that word anymore, and that makes you slip in your shoes, whether you have rugs in your home, but it's lighting and floor coverings that can cause some of the falls. Now, I don't know if I told you this before. For women, we talk about key and door, feet on floor. For many people who get up in the middle of the night who have held their urine, they get up, and especially women, and they start to urinate when they put their feet on the floor, and then they start to run and they fall. So that's a source of falls. So it's balance and posture, and we talk about Tai Chi can improve somebody's balance no matter what age they are. But your goal is to prevent falls. So when you talk with the elderly, depending on what age you look at, 60 to 75, 75 to 85, 85 or older, and you're interacting with them, you have to do some fall risk assessment and evaluate their balance. The easiest way to evaluate their balance is to walk and watch in the room, or to ask them to get out of a chair and see if they can do that by themselves. If they put both hands on their chair and they lift up with their arms and their feet close, and if they can do that. And of course, the neuro problems with the elderly is the cognitive changes of elderly. I read that 10% of those 65 and older have some types of dementia. Alzheimer's dementia accounts for about 80% of the dementia, and it's not preventable, and the drugs don't seem to change the course of the disease. And I've read that some of those mental games don't seem to help the person, but it's hard to know. It's hard to know what is false hope and good hope for the elderly. So, but your goal when you interact with those people in an office visit who are elderly is to find out if they have memory deficits. Remember that dementia is a problem with coping as well as cognition. And at some point you have to identify, do they have cognition changes? Whether you use the mini mental status exam or the clock exam, you have to use something on a routine basis so that you can evaluate the functional changes. Now, many times when people have dementia, it's the family that brings them in and they notice the changes. But now we have people who live alone, and so it's hard to notice when they do have the changes. So with neuro and aging, we talk about dementia, and then we talk about stroke. And stroke is the ischemic stroke as well as the hemorrhagic stroke. And your goal is to prevent that, to teach all your patients and to put those signs of FAST in your office so people know the signs of stroke. They can get to a healthcare center, and they can get, if they're actually having a stroke, they can be worked up and have the medications that they need on board, and recognize for many people the most important thing is blood pressure control. And it's important for you to set those blood pressure parameters for those patients in your practice. I had a lady who came 2 days ago, and the family brought her in because she had excessive high blood pressure of 173. And the last time they were in the hospital, I told all of them that the goal of her blood pressure at 85 was 160. But they thought 170 was so far removed from 160 that she had hypertensive emergency and brought her to the ER. When we talk about the neuro and aging, remember that we talk about the CNS, the central nervous system, as well as the peripheral nervous system. And I'm not quite sure where pain comes into this. I would tend to think pain is a musculoskeletal as well as a neurological change. So we have to talk about changes in our central nervous system and peripheral nervous system and talk about how you evaluate for those in your office visit. It's important for anybody over the age of 65 or any patient that you do a medication review, but especially for your older patients, how many medications are they on? Do they interact? We're doing CPO, which is computer program order entry at my hospital, and now when you put in order a medication, for every medication you order, it will tell you if there's a synergistic effect between the other medications and which medications don't go. And if you choose to give that medication, then you have to give a reason for choosing to give that medication. I'm sure all of you know that, isn't it? Zofran and Levaquin can't be given together. We don't use Demerol in most facilities because of its problems. Do use the Phenergan in the elderly. Now, there's a list of drugs called the Beers criteria about drugs that have been noted to increase the falls and change the cognitive function of the elderly. So it's important for you to know which are on the Beers criteria and to know if you can prescribe them in your facility. I've worked at the VA, and we had for a couple of years, and I had a few floors, and every month I was challenged if the average patient had more than 4.5 meds. So the least amount of meds on a routine basis was important. I had a person that was admitted the other day that had 32 medications and didn't want me to take any of them off. And I think there's some new rules with Medicare, aren't there, about how many they will actually pay for. So please note when you're assessing the elderly that you have to know about do they use alcohol, how frequently do they use alcohol, do they drive and use alcohol, do they use tobacco, do they use illicit drugs, whether it's ecstasy or marijuana, and do they combine drugs? It's not related to age. The other is, do they use prescription drugs and over-the-counter drugs? It's important to know those. Do they interact? Do they have grapefruit with their drugs? And are they engaged in the use of illicit drugs? Now, the definition of illicit drugs is using a drug that doesn't have your name on it. This is the percentage of prescription drugs used in the past month by the age. And as you can see, the older the person gets, the more likely they are to use prescription drugs. So what are the components of a comprehensive geriatric assessment? It's medical assessment. You have a problem list. You understand what are the comorbid conditions and the disease severity. If they have rheumatoid arthritis as well as osteoarthritis. If they have chronic congestive heart failure, stage 3 New York classification, as well as stage 3 of the gold classification for COPD. What is the severity? Is the osteoarthritis severity 2 to 3? They take Tylenol occasional. They have no changes in the physical function of their body. Or is the disease severity so much that they can only stand for 10 to 15 minutes a day, that they use a walker, that they can't go through their house without holding onto the wall, they can't get in and out of a car gracefully, do a medication review, who's giving them their meds, are they getting them refilled, do they take them on a routine basis, can they afford them, nutritional status, A cholesterol is a inexpensive pre-albumin, but it's important for some of those medicines to know if they're albumin bound or not albumin bound. I had a lady who came, an 85-year-old who came in the hospital last week, and she had a digoxin level of 4 and an albumin level of 1.5. She had just quit eating about 2 weeks ago and kept taking her albumin, so you have to be aware of that. Assessment of functioning, or do they engage in the basic activities of daily living? Do they shop for their food? Do they cook their food? Do they put away their food? Do they clean their house? Do they do their clothes? Do they groom themselves independently? Are they active? Do they exercise? And it's nice to say that the elderly need to exercise, but activity is very important. What is their gait and balance? Nothing wrong with asking them to get out of the chair, get back in the chair, walk around the room. What is their psychological assessment? What cognitive testing do you use in your facility? You can ask about mood and depression testing. I can remember asking an African American male when I worked at Emory if he'd ever felt blue, and he looked at me and he goes, I've never really felt a color. And the word sad or depressed wasn't in his vocabulary. So we have to use the words that the person appreciates. Now it's nice. I think the DSM-5 has come out and it has some new definitions for depression, I think, as well as dementia. So you have to know the hallmarks for depression and the different types of depression. There can be psychotic depression and reactive depression. And for the elderly, we say that for 2 or more weeks they have a loss of enjoyment in life, and this is called anhedonia. They have a 10-pound weight loss. They have trouble making decisions. And you want to talk about depression. When you look at the statistics for treating depression, about 30% of the people get better in 90 days, 30% of the people get better with drugs, and 30% of the patients get better with cognitive behavioral therapy. And so it's important to know what drugs we're giving the patient. And if you think they're depressed, you have to do a suicide risk assessment. Do they have a plan? Do they have access to that plan? Have they tried it before? Has somebody in their else in their life tried it before? Is it appropriate in their culture to kill themselves? For the social assessment, who is their healthcare proxy? Who is their next of kin? Do they have NOK on their phone? Have they talked to significant others or their healthcare proxy about their end-of-life wishes? Not a patient who came in the hospital the other day, and you all have that same patient. And do you have an advance directive? Yes, I do. Where is it? My doctor has it. Where is your doctor? He's in another town. Well, what does it say? Well, if I knew what it said, I could tell you, but I don't. He has it. Well, what would you want me to do if your heart quit beating? And this lady said, what are my choices? And I said, well, I could pound on your chest or I could hold your hand. She goes, I think holding my hand sounds better. And I said, what would you do if I quit breathing? And she goes, what are my choices? I said, hold your hand, or I can put a tube down your throat. And even though I asked those questions and she asked me to provide comfort care, I didn't believe there was somebody else in the room that she had actually thought that through. So I made her a full code. And why I say this is you have patients who come in the hospital and they have an acute pneumonia episode, and even though they have a living will that says no advance directives, they actually do put them on a ventilator for 2 or 3 days, or they go to surgery and they end up on a ventilator. I know I did nephrology for 5 years, and so many of those patients said they had DNR statuses, and I just couldn't get over the fact that they didn't think that dialysis was a life-saving technology. And you want to know who should we call, when should we call, and are you comfortable with their decision making? And sometimes they are, sometimes they aren't. The environmental assessment is, do they have home safety? Can they get in and out of their home? Do they have a life alert? And can they have transportation? And do they have telehealth? Now, the other thing that I tell that any patient, I always ask the patient to list on one sheet of paper all their medications, their doctors, their surgeries, their allergies, and carry that with them. So if you can do that at any point in the office setting, so when the patient leaves, they have a list of their medications, their surgery, and their problem list, and they can carry it with them wherever. That's a kindness you can do to the patient. I also tell people who have living wills to keep it on their refrigerator as well as their medication list. Um, some of them do, some of them don't. Office visit for the elderly. Recognize when you plan this, it usually takes longer. The person may be hard of hearing, may have slower cognition, they have more questions. Recognize you're the head of the team with multiple specialists. I was talking to a Medicare patient the other day, and she said she was only allowed 13 office visits a year, and she had to figure out when she was going to go to a pulmonologist, when she was going to go to a rheumatologist, when she was going to go to her endocrinologist, when she was coming to her nephrologist. So you have to coordinate that. You have to talk about what are the goals of the healthcare, quality or quantity of life. When do we continue with preventative screenings? When is the quality of their life or their comorbidities so bad that we don't do preventative screening? You have to be real clear on what are end-stage diseases, what is stage 4 cardiac disease, what is stage 4 COPD disease, what is metastatic cancer, what is end-of-life care. And you just have to, if you can't make that decision, I tell people, if you can't make that decision, we'll make that for you at that time. Do they have a health care proxy? If they do, that's important to put that on the phone. I don't always remember that. Do a medication review. You can do it, or your anybody in your office can do it. Frequency of visits, sometimes it's very difficult for that patient, especially if they can't drive, to get to your office, and you have to know how often they can come. Now some people actually go to their homes. And what is frailty? And I'll talk to you in a moment. And neurological function, and neurological means gait, balance, and cognition. So with the patient, some of you may work in a situation where you have a whole team of people, therapists, nutritionists, neurologists, psychologists, all these people that help with a geriatric patient, and some of you don't. So with the aging review of systems, recognize visual, they have a loss of vision, what types, hearing loss, what is available in your community to assist with that. Is there a change, a rate, rhythm, murmurs? Talk about shortness of breath, fatigue, orthopnea, especially systolic hypertension and hypotension. It's very important to teach patients who are elderly if they have a 5-pound weight change, if they lose weight, then you ask them to take their blood pressure sitting and standing about 2 hours after they take their medicine to see if they have orthostatic hypotension. You need to determine what the goal of that blood pressure is. Do they hold their blood pressure medicine? If their systolic blood pressure is below 120, below 100, below 140. And then you need to have a sick day routine. If they wake up and they have nausea and vomiting, and they're on a calcium channel blocker and a beta blocker and an ACE inhibitor, this is not the day to take those medicines. So talk about a sick day routine. Pulmonary, do they have cough, shortness of breath, dyspnea on exertion, PND? GI, what is their definition of constipation? What do they use? How does this bother them? Do they have blood in their stool? Do they have fecal occult blood testing on a yearly basis? For women, 50% of women over 50 have incontinence. Do they have stress continence? Urge incontinence. I was at Sam's the other day, and they have an over-the-counter, I think, oxybutynin. And now they even use Botox for women. So do they want to try those drugs? Do they want to continue PAD? Do they want to go to a urologist? I think it's important. The research I've read on teaching the elderly female Kegel exercise and have her do 100 an hour within a 1, she would have less stress incontinence. Once again, please tell these patients when they go to bed at night and not to get up in the middle of the night, urinate, fall, and you talk about that. musculoskeletal joint and back pain and weakness and limited range of motion. It's important to move the joints. You can do that from a sitting position. Make that part of their routine. The more you move, the more you can move. In neuro, you want to talk about what's syncope, pre-syncope, transient, what's a TIA, what is a stroke, and so they have those symptoms and who to call. Extremities, you want to talk about one leg swelling, both legs swelling. People come in and they're morbidly obese and they drink 3 liters a day and they want Lasix for their feet. We have to talk about, do we give that Lasix? Do we talk about elevating their feet? Their feet have to be above the level of the heart for it to do any good. I tell people to lay on the ground and put their feet up against the wall, and they laugh at me and said, then who would get me up? Aging PE, state of health, you do all these things. Once again, vital signs, it's important. Take the right and the left side, sitting and standing. If you need to set up in your office, if the blood pressure is elevated, whether it's 160 or 170, does the staff know to repeat that blood pressure in 5 minutes before you get with them? And then what are the expected aging for each of these organs, and what specific situations do you ask about? These are the chronic reasons that people die: ischemic heart disease, cerebral vascular disease, malignant neoplasms. We talk about chronic health conditions. I said arthritis was the most common, as well as hypertensive heart disease. Remember, if you have atherosclerosis, then you also have peripheral vascular disease, and you have to monitor for that. Alzheimer's disease, the older you get, the more apt you are to have it. Females have it more than men because we as women live longer. Stroke and cancer are part of aging. You want to know, is there a physical disability that prevents independence and autonomy of normal life? And how is that interacting with their life? And when we talk about the elderly, we have to talk about mistreatment. The most common form of mistreatment is neglect. The goal is no elder abuse. In our facility, they ask patients in the emergency room, do you feel safe in your home? And sometimes you find that people aren't eating. You find out they don't eat because somebody is not bringing them the food, or somebody is cashing their Medicare check. I see consistently people on hospice, and they come in pain, and they're somebody in their family who is supposedly helping them with health care is stealing their meds. So elder mistreatment as well as frailty in the elderly. Now, what's the definition of frailty? Frailty is when you have a medical condition and one lack of independence in your health care. It's usually associated with the people over the age of 75. Once again, it's lack of independence and one ADL and a comorbid condition. So this would be a person who is 75, who needs assistance going outside of the house and is on oxygen. That's a person who's frail. When you have frailty in an individual, anytime you do testing or send them to a specialist, you need to talk about the benefits and risk of workup and treatment for those diseases, because you can't predict how much longer they are going to live. Now, there are some clinical frailty scales, and you have to find out what is available in your institution or in your office, how you use that, and what information we use because of it. Once again, you want to know, when you assess them, are they fit or frail? Are they vulnerable? And what is their life expectancy? Do you work them up for cancer? Remember, cancer comes with aging. Do you not? Do you treat them? And when is the treatment curative? When is it palliative? When is the benefits of treatment outweigh the risk of treatment? So, in summary, I think I've aged during this presentation. I would like to know, do we age gracefully or with frailty? Remember, frailty is over the age of 75 with one lack of independence in ADL and a comorbidity. What is the expected system age versus the disease? When we talk about the disease, what stage of the disease and severity? You should know what are appropriate changes in the body system by system, especially with medications. When you do the comprehensive geriatric, what are the functions of that disease? With a review of systems and PEs, what are the expectations? With frailty, what's the definition? With elder mistreatment, what's the definition? And thank you for your attendance, and I hope you have a great rest of your life. Thank you.